Hello, this is the online lecture for Lily Chapter 3 Lifespan Considerations, really focusing on the big things, the need to know things, so this is short and sweet. There are some major differences between pharmacokinetics. Remember, that is what the body does to the drug. There are some big changes between, for instance, the woman that's nursing the baby, children as they develop, pregnancy in the different trimesters, and then as we get older adults, as we know, the organs can start to decline and not work as well. So let's talk about pregnancy first. So drugs do cross the placenta by diffusion to varying degrees. Some different factors about how safe a drug is during pregnancy are the actual properties of the drug itself, how far along the mother is, so how old, or the gestational age is how many weeks along the fetus is, and things like the mother's health. And what do you think is the trimester that has the greatest risk to the fetus in terms of drug therapy? So the greatest risk is actually during the third trimester. And the reason for this is because that is when there is the most placental blood flow, so that baby is getting bigger and getting more blood from the mom, and so there are more risks that can happen. So during pregnancy, there are different safety categories, and they've been saying since I started teaching that they're going to get rid of these categories, but we still use them quite a bit just because it kind of gives us common language. But there are new categories that are in progress for pregnancy, lactation, and then even for females and males who are capable of having children, so people that have reproductive potential. So again, A through X. So we'll talk about A through. So like I said, we're getting away from these categories, but because they're still commonly used and it helps us to conceptualize the safety of medications, I'm going to go ahead and teach you these categories. So category A is where we have no information at all that there's harm to the fetus, and we even have studies on pregnant women that show that there's no risk. So examples of category A, that'd be something like folic acid, which is something we actually recommend for people to take when they're pregnant. There's not a lot of data on many different drugs because it's not ethical to do randomized, controlled, double-blind studies on pregnant women. We don't want to experiment with babies. So some of these we don't have a lot of information, but we go with what we have. So category B, in animal studies, we don't have any risks shown, but we don't have enough information to know for sure if it's safe. So examples of category B, that would be things like acetaminophen. So like Tylenol. Category C, this is where in animal studies, we have seen that there's some risk, but there's no adequate studies and no definite proof that there's harm to the baby. So category C is not ideal, but the benefits of the drug might outweigh the potential risks. A couple examples of category C would be SSRI medications like antidepressants and prednisone. Prednisone is a steroid. And so if, for example, I've taken care of women who are having like an asthma attack, and a lot of times pregnant women are very afraid to take any medicine because they don't want to harm their fetus. But what I always tell people is a healthy mom is the most important thing for a healthy baby. So for example, if that woman is having an asthma attack and she needs to have some steroids to help, then that would be a reason where the benefit would outweigh the risk. Okay, so medications that are really not good to give are categories D and X. Category D, we know for sure that there is positive evidence of human fetal risk. But this is something where if the mother is very, very ill and it's a life-saving medication, the benefits might outweigh those potential risks. So for serious or life-threatening situations. The only category where you absolutely cannot ever give it, contraindicated, remember that means we don't ever do it, category X. So studies in animals or humans have demonstrated fetal abnormalities or there's actual evidence of fetal risk. So categories D and X are when things get a little bit more tricky. So category D, there has to be a real definite reason to take this because we know that there's positive evidence of human fetal risk. However, category D drugs, definitely not ideal. These might be given if the potential risks are outweighed by the potential benefit. So this would be something like a serious or life-threatening situation. Example of this would be something like phenytoin, which is a medicine for seizures. lithium, which is a medication for bipolar disorder, so if the mother had severe mania, or warfarin, which is a blood thinner. So we know that these are high risk, but in the right situation, they might still be indicated. Category X, there's no reason these should ever be given. So these are where there's studies in humans and animals, and we know that they cause fetal abnormalities or even fetal demise. So these medications are contraindicated. We should never give a Category X drug. A couple examples of Category X would be some types of chemotherapy and immunosuppressants, such as a medicine called methotrexate, and several types of chemo. Another medicine we'll learn about next week is called misoprostol, and this is actually used to induce labor. And so as you can imagine, if somebody takes a medication that we use to induce labor in late pregnancy, if a person was to get this in early pregnancy, it would actually cause them to have a miscarriage. Breastfeeding. And so breastfed infants are at risk for exposure. There's the drug level is usually lower than in the maternal circulation, so often it's a lower amount than if it was in the placenta where it's direct blood flow. And so we always have to think about risk to benefit situations. For neonatal or pediatric consideration, so for little tiny babies all the way up to children, absorption is a little bit unpredictable for little kids. And so the gastric pH is less acidic in early childhood, so up until ages 1 to 2. And gastric pH, the acid in our stomach actually kills bacteria. And so kids less than 2 are more at risk for bacteria to survive in their stomach. They also have slower gastric emptying, and so we might have delayed absorption. And then the liver is reduced, the liver is immature, and so there's less of that first pass elimination. So increased risk of toxicity. And if kids have intramuscular injections, the absorption is faster and less predictable. So that was for absorption. For babies and kids, for distribution, they have a greater amount of total body water, and so they have lower fat content. They have decreased level of protein binding, and the blood-brain barrier that we talked about that keeps out toxins, pathogens, and a lot of medications, it's immature, and so there's more of a chance that drugs can get into the brain. For metabolism for babies and kids, the liver is immature. It doesn't make enough of those enzymes that metabolize drugs and toxins. Older children can have increased metabolism. So we talked about inducers of metabolism. And so older children, their livers are so healthy that they might actually need increased doses. And so if their metabolism is really strong and really high, they might actually need to have more medication because their body is breaking it down. And then for excretion, there's decreased perfusion. If there is decreased perfusion in babies, then they might have delayed or reduced drug excretion. The way that drugs are calculated in pediatrics, there's different ways. The most commonly used is body weight. So the most common way that drug doses are calculated for kids and babies is milligrams to kilograms, so body weight. Other ways that can be used are things called the West nomogram, which is looking at body surface area. And always remember for kids that we use kilograms, not pounds, and we use centimeters, not inches. So in between children and older adults, we have young adults and middle age. Those are pretty general to the things we talked about. So now we're going to talk about what happens with older adults. Older adults have more medications, they have more things wrong with them or comorbidities, they have multiple illnesses, they might have sensory and motor deficits, and our organs are going to gradually decline as we get older. Some are going to decline faster and some are going to decline slower, but the more that those organs are not working as normal, the more we have a risk of adverse effects and particularly toxicity with medications. For absorption in older adults, the gastric pH is less acidic. The gastric emptying is slowed down in the movement through the GI tract. There's decreased blood flow to the GI tract, and there's less of a surface area in the GI tract. So there can be difficulty, there can be decreased absorption of medication. For distribution, older adults have lower total body water percentages and increased fat content, and the liver makes less albumin and other proteins, and so there's decreased sites for protein binding. And so this can lead to increased risk of toxicity. Metabolism in older adults. Again, the liver is aging and it's making less enzymes, and so there can be a decrease of drugs being broken down. There can also be reduced blood flow to the liver. And with excretion, as the kidneys start to slow down, there's decreased GFR. I'm not sure if you know that word yet. So that's glomerular filtration rate. So that's how efficient the kidneys are doing. So the kidneys are slowing down their rate of producing urine, and the nephrons are dying, and this can lead to decreased excretion, and so there can be accumulation of medications. For older adults, just some general tips. We should ask about every provider the patient sees. A lot of older adults might have multiple doctors. They might even use multiple pharmacies, and so it could be that they're on medications that actually have bad interactions. They might be on duplicate medications, so we need to say, what are all the doctors you go to? What are all the pharmacies you go to? What are all the over-the-counter drugs? And then we have ways to assess risk situations in older adults. There's something called the Beers criteria. And so this is a list. You do not have to memorize all the Beers criteria, but this is a list that is updated frequently, and it gives guidelines for medications based on risk. One example is it might say, one of the criteria, it says that older adults should not be on benzodiazepines. They also should not be on NSAIDs chronically. So the Beers criteria just gives recommendations based on risk. It doesn't talk about dosage. It doesn't talk about specific labs or any of that sort of thing. It's more guidelines. Hey, older adults might not be a good candidate to use these certain drugs. They might talk about interactions. And then for implementation for older adults, we need to make sure that they take their medications as directed. If they miss a dose, they should not double up doses. They should never stop a medication without talking to the provider. And then we always need to be aware of polypharmacy, and that is where people are on multiple drugs. And so the more drugs that somebody is on, the more medications, the more risk there is of toxicity, interactions. And so for older adults, we need to do a really strong assessment and make sure that we're looking out for safety concerns. And that's it for lifespan considerations.